morning. I'd like to start off by thanking the club for the opportunity to give my perspective on kind of an interesting topic, how to onboard a new thoracic surgeon into your practice. I hope that the talk will give both experienced surgeons who are thinking about bringing in a new thoracic surgeon some perspective, as well as junior surgeons or residents who are looking for jobs, kind of help them decide what they want to look for and the questions to ask as they're interviewing at a new position. Today I'll primarily focus on how to bring in a new thoracic surgeon. Certainly the challenges that would come with bringing a mid-career surgeon into your practice or a division chief, for example, into your practice will be different and unique than what it takes to bring in a new surgeon. So again, this talk's simply my perspective, having come out of training 3 years ago, having been involved in the recruitment of another thoracic surgeon into our practice, and having seen variable onboarding experiences of my colleagues over the last 3 years. So there may be many reasons you're considering bringing in a new thoracic surgeon into your practice. Maybe a partner's retiring. Your practice may be growing, and you want to develop improve the patient access and satisfaction. Perhaps you want to expand it to another hospital and establish a stronger footprint in your region. Maybe you want to introduce new techniques to remain competitive in the marketplace. Or maybe the recruitment of a new surgeon may be a means to develop educational or research programs at your institution. So when is the ideal time to bring in a new surgeon? As uncomfortable as it may seem, particularly for other junior guys in the group, you should probably consider bringing in a new thoracic surgeon before the practice is maximally deployed. This allows the practice to continue to provide top-notch care without overextending the existing thoracic surgeons. It generally takes at least 6 months to go through the process of recruiting and bringing in a new surgeon. And if you guys are running at 100% when you start thinking about bringing someone in, then you're going to be running at 100% and potentially be overextended, not providing as good of care as you would have otherwise. And like I say, this also allows the existing surgeons the continued flexibility to pursue academic interests or attend to new patients that are coming into the practice in a timely manner. So with that said, I do think a certain space between recruits is necessary. I'd say recruits should not be brought in any earlier than 2 years apart. This avoids the almost certain sense of competition and feeling that they'd be getting more mentorship or resources or business had they been brought in alone. Perhaps the most important question, though, is who should you recruit? If your practice is like most, you're going to be spending a fair amount of time with your partners, perhaps more than you do with your own family. So you guys have to work well together. And you can only get so much about a person from their interview. Luckily, we're a relatively small group of thoracic surgeons across the country, and a phone call to a trusted colleague can often get you good information about a person's work ethic, their technical abilities, how they get along with other people. Try to understand if that recruit's personality will fit your group. Now, that's kind of a hard one to quantify, but I think above all, the recruit has to be someone who the other partners in the group trust. Trust to take care of their patients, trust with the financial aspects of your practice, trust for backup. You also want to look for someone who has a passion for people. And I say this primarily from a business perspective. Every partner in a practice has to have the ability to engage patients, make them feel comfortable, and gain the trust required to get that patient in the operating room when it's necessary. So you can't really afford a socially awkward partner who's going to reflect poorly on the practice, particularly if you work in a competitive environment like Chicago, for example. So when choosing a new partner, you have to decide what the envisioned role of that person is going to be prior to even starting the recruiting process. The ideal recruit will have interests and strengths in the needed domain. The surgeon who's best fit, say, to start up a thoracic surgery line at an outlying community hospital is probably not the same surgeon that you're going to bring in to obtain funding and expand the research efforts of your department. So that should be clearly defined in your mind prior to starting the process. By selectively hiring and deploying people according to their strengths, I think you can build a diverse, broad-based, and versatile practice. Other things to consider when you're talking about who you're going to recruit. Will the recruit fit well into the community that your practice serves? Is he or she from that area? Do they have family close by? Are they married? Does their husband or wife require professional recruitment? These are all things that you need to consider as you're looking for a new person. Are there good schools for your children? The bottom line is if these vital aspects of recruitment are ignored, you're probably going to be looking for a new partner in a couple of years. So these are important and cannot be overlooked. So step one, before starting the recruitment process, you need to make sure the proper resources are available before bringing in that surgeon. In their first year, a surgeon out of training will only generally produce about 33% clinical productivity, that of a mature surgeon. 50% is probably a reasonable goal by year 2. And by their third year, that generally rises to about 75%. For that reason, most new thoracic surgeons are going to look for a 2 to 3 year contract, which guarantees them income during that initial growth period. If you're in private practice, that means that you're going to lose money initially. So you have to be able to absorb that loss. The good news is most of us are in academic settings where we have an institution or a hospital or a medical school that will help to backstop some of those losses. So, the compensation package. Young surgeons leaving training almost invariably have a huge amount of debt from the last decade of training that they'd been going through. When it comes to salary, you don't necessarily have to be the highest bidder, and I think this is an important point. You do have to be, however, in the ballpark of the other offers. Most general thoracic surgeons I know practice for about 2 years before getting their heads above water financially. So, if you want to sign a good recruit, if you have a person in mind, come to the table with a reasonable offer. And that's going to vary depending on whether or not that recruit is doing cardiac and thoracic surgery, just thoracic surgery, what region of the country you're in, and if you're in an academic or private setting. All those things will affect how much that number is. To sweeten the deal for a potential recruit, you can offer them signing bonuses, potentially year-end bonuses, things along those lines. Annual expectations for annual raises will help bring in these recruits. But it's not just salary that you have to take into consideration. Even if you're not the highest bidder, offering other resources oftentimes can help pull in a new recruit. For example, in our practice, with each new surgeon that we hired, we brought in a PA and an administrative assistant. So help in that regard is important. Now, if the surgeon you're bringing in has research interests, perhaps space, equipment, funding, protected time, all of these things need to be considered in the cost of recruitment. Remember, when you're recruiting a potential partner, it's important that you sell them the truth. Nothing else. And the reason I say that is because if your partner comes in and only to feel that you've misled them in the recruitment process, they're not going to be happy, the trust will be broken, and that's not good for the recruit or the practice. So, as part of the contract negotiations, you should explicitly state and put in writing exactly what you expect of that new recruit. What clinical productivity is required? What call coverage will you expect of them? What academic productivity is required? What if they don't pass their boards? How is that going to affect their job? But simultaneously, and importantly, lay out a plan for that new recruit of exactly how you're going to make that happen, or how you're going to help them make that happen. Do they get block time? What kind of marketing strategies are available to them? How are they going to get busy? That's what recruits almost invariably want to know. Are they going to get all tumor board cases? Are they going to split cases evenly that come in the door? Are you going to give them some of your patients? Are they going to get all inpatient consults? Whatever the construct is that you come up with and agree upon with the new recruit, these are things that you need to lay out before even signing the contract. Is there an established investigator that will help take them under their wing if you're bringing someone in to expand the research efforts? Will you pay for board review course? All these things can be laid out, but not just giving them expectations, but also telling them how you're going to help them meet those expectations. One special note, I think, you need to set goals excuse me, that with hard work can be met by their new recruit. Don't set a goal of 10,000 RVUs and an RO1 in their first year. Set goals that are reasonable. It's a win-win situation if your recruit comes in, is productive for the group, and is rewarded by a bonus or a raise at the end of the year. So, great, they signed. And this is the kind of thing that I think fellows and residents, as they are looking at new jobs, should take into consideration. Sit down early with your new partner and make a 1, a 3, and a 5-year plan based on your mutually agreed upon goals. As an example, maybe in your partner's first year, you'd expect them to produce 5,000 RVUs, begin to operate independently, have good outcomes and demonstrate good judgment, pass their boards, maybe give 5 CME or outreach talks, and maybe publish 1 paper. These were essentially my goals in my first year that my chairman sat down with me and laid out. By year 3, maybe you'd expect them to produce 8,000 RVUs, start to be turning over most of the cases to their fellows, take on more increasingly complex cases, maybe 3 publications per year is a reasonable number at that point. Start to have more societal involvement, potentially hospital committee involvement, maybe obtain a career development grant. By year 5, I'd say that 10,000 RVUs is a reasonable goal, depending on your practice setting. You'd want to see your recruit start to take on the most complex cases out there. Maybe you'd expect them to be promoted to associate professor, meet all of the requirements by 5 years to do that. Take on leadership roles, maybe in the division or in the section, potentially leadership roles in various national committees. Perhaps join the AATS by that point. Unless they inherit the practice of a busy, recently retired surgeon, most new recruits aren't going to have a booming clinical practice in their early years. So you want to encourage them to use that time to study for boards, to do research, and to write papers. That way, their academic career grows in parallel with their clinical practice. Pretty soon, with availability, affability, and ability, the cases will come, and pretty soon they'll wish they had more time to pursue their academic interests. So it's all fine and good to set goals for a new recruit and tell them how you're going to help them make it happen, but you have to mentor them. All new recruits need mentorship, and the transition from a resident to a capable surgeon certainly doesn't happen overnight. It's variable for every surgeon, but it's never overnight. So, number 1, how do you mentor a new recruit well? Number 1, you have to always have their back. Young surgeons are going to need support for decision making when they get themselves in trouble in the operating room, but you don't want to smother them. You need to let them operate independently. That's the only way that young surgeons can develop the confidence they need to ultimately become a competent surgeon. So don't always be in the OR while they're operating, but if they call, always show up. You need to also be completely honest with your new resident or with your new recruit in evaluating their performance. Young surgeons want to hear what they could have done better, what they should have done, and that they did a good job when it's warranted. Help them develop relationships with referring providers. And I know that may seem kind of scary, particularly if you work in a relatively competitive environment, but believe me, it's almost impossible for junior partners to steal their senior partner's practice. So you want to introduce them to referring doctors, get them their own referral patterns, and help them grow in that regard. Protect your junior partner from extraneous draws. I was told day 1 when I showed up at Rush, don't join any hospital committee without talking to me first, because the junior partners are going to be invited to join every committee you can imagine as soon as they show up. And oftentimes, those are not going to help them really in any way. Then, provide opportunities for your junior partner that you feel will help build their career. For example, I was introduced to the STS database task force when I first showed up at Rush, and it's been a great opportunity for me from a networking standpoint and from a learning standpoint as a young surgeon. Then work to foster group loyalty within your new recruit. What does that mean? How do you do that? Ultimately, I think it's pretty simple. You just work harder than them, you take call like them, you guide them with your experience, your knowledge, be fiercely loyal to them, and inspire them with your confidence in them. If you do all this, it helps to build in this new recruit a feeling that they're part of the team, that they can do this. Then they ultimately prove to themselves that they can do it as they get themselves in and out of trouble in the operating room and take care of patients. I think it's important that you also regularly review your recruit's progress. The best way to do this, I think, is with regular informal talks. It's always better to nip any issues in the bud than to wait and allow those things to build, which oftentimes lead to more difficult conversations later. Then, at the end of each year, arrange a formal meeting to review the goals that you set at the beginning of the year. If the goals were met, and a bonus was agreed upon, give that bonus to the recruit, and then give them a raise the next year and set new goals. If the new surgeon did not meet your expectations, you have to be completely transparent with them and explain what you had hoped for. And these aren't always necessarily easy conversations to have. These situations generally fall into one of three categories: professionalism, gaps in training, and bad judgment. Professionalism issues are generally the easiest to spot. Say it's a skilled surgeon who has good outcomes, has good judgment, but he keeps yelling at the OR staff and keeps getting written up. How do you approach something like that? Generally, if you want to approach this in the best way, you'd point more to the issue than the surgeon. You might say, hey, great case, the patient's gonna do really well, but if the staff is yelled at too much, they're just not gonna work that hard for you. And then kind of point to someone who gets it. Hey, look at John over there. He's always in a great mood. He's never yelling at the OR staff, and the staff will do absolutely anything for him. Then that's the hopefully ways continuing to reinforce that type of approach will help get to your recruit and get to the bottom of these professionalism issues. Gaps in training can be a little bit more difficult to deal with. You might start with the old, hey, we've all been there. Let me tell you about the first time I saw the inside of the PA, son, and then kind of move on to how you'd plan to address this deficiency. Maybe you send them to courses. Maybe they double scrub cases with you. Maybe you send them all of a certain kind of case so they can get comfortable with that case. But you need to make it clear to your new recruit that you expect them to take all opportunities afforded to them to remediate this deficiency. The final category is bad judgment, which I think is probably the most difficult to address. Because you have the risk of coming off here as a my way or the highway kind of partner. And so you have to take a step back, I think, and assess the situation. Ask them, are you telling them not to stent to esophageal perforation because that's something that you've never done? Or is it because the outcomes would be better with a formal operation? And if it's not a matter of innovation, but a matter of effectiveness, then you need to get on the same page. So you might say, hey, listen, I noticed you stented that esophageal perforation after 5 days gross contamination. You didn't wash out the chest. Why didn't you just operate on them? And then fill them in on how things should be done from the standpoint of the desired outcome. Hey, listen, I know that minimally invasive approaches generally seem like a good idea, and oftentimes they are a good idea, but maybe not in this case. Finally, cutting ties with a partner should generally be kind of a last resort. But if performance issues continue, doing so avoids the ripple effect of negativity, low morale, and poor quality work. So I think at the end of the day, hiring a new partner can be a daunting task. It requires a lot of foresight, an established game plan. There are a number of moving parts that must be orchestrated to make the recruitment successful. However, I think if you use some of these tenets as a framework, the recruitment of a new surgeon can be a positive and rewarding experience that will lead to a lasting partnership. Thank you.